Just a brief overview. The Marjorie Hinckley Endowed Chair has a financial endowment in the College of Family, Home, and Social Sciences. Funds not only this lecture this evening, but also faculty research, mentored learning grants. There are many opportunities for students to collaborate in active research in the college with faculty. Student scholarships and internships are also funded by this endowment, and also student travel to conferences where they often present their research to a professional audience. We are grateful to all the generous donors in particular who have contributed over the years to this endowment to make all of these activities possible. At this point, we want to share a brief tribute video for the Marjorie Hinckley Endowed Chair. This will better acquaint you with Sister Hinckley, especially her warm character and faith. So let me proceed to that.
On April 29, 2003, the Brigham Young University College of Family, Home, and Social Sciences announced the establishment of an endowed chair in the name of Marjorie Hinckley. The chair is a fitting tribute to an extraordinary lady and her lifelong commitment to the development of the whole woman and the strengthening of parents and children. Wife of Gordon B. Hinckley, 15th President of the Church of Jesus Christ of Latter-day Saints, Marjorie frequently accompanied her husband on trips of goodwill across the globe. Over the years, she left a powerful impression of virtue and kindness with millions of people who affectionately referred to this loving matriarch simply as Sister Hinckley.
I try to make people feel comfortable with what they are and who they are, and let them know that they're appreciated, that they're making a contribution. They are. People generally are good. In the church or out of the church, people are good.
It was in the spring of 1937, as America struggled in the grip of the Great Depression, that Marjorie married Gordon B. Hinckley in the Salt Lake Temple. But in spite of economic challenges, Sister Hinckley faced life with the bright outlook that would eventually become one of her trademarks.
Just before the wedding, Dad confessed to Mother that his total net worth consisted of a $150 savings account, and that perhaps they should postpone their marriage until he could accumulate enough to support her. In her typical cheerful way, she exclaimed, "All I was expecting was a husband. And now I had $150 as well." I was thrilled.
When I look back upon our early years, I tremble to think of the little money that we had to live on. I earned a very small salary, but that was the bottom of the Depression. A few dollars bought a substantial supply of groceries, and we made it all right. We built a pleasant home in East Mill Creek and settled down and reared our family there. 3 daughters, 2 sons. It was a very lively household, and the mother of those children was the very center of it. She was a tremendous worker, a hard worker. She was always planting flowers, doing this, doing that, beautifying the home, serving in the church in a variety of capacities, and rearing her children. She's been the lodestar of their lives, and they all look back to her as the source of inspiration and one to have a happy time with. They love her, she loves them.
A central figure in her own family, Sister Hinckley also became a champion for the family both here and abroad. As she traveled the world, the counsel she gave centered on building stronger, happier homes.
Mothering really is hard.
Even at this age.
But it doesn't mean you can't love it. And so I would say to all of you, have joy in your mothering. Especially wonderful were the summers when the children were young and home where I could be the boss. I did my best to keep those summers unstructured so they'd have time to explore. and lie on their backs and listen to the birds.
Mother, over the years, your advice and influence has shaped my life. What message would you like to share with these women today?
I don't know. Don't worry, I've got it written here. My advice is to be the best person you can be. Profound, isn't it?
Although her impact on those around her was profound, it was Sister Hinckley's sense of humor that many recognized as her most endearing trait, one that was manifested consistently in her relationship with her husband.
We learned long ago that you can't take life too seriously. You just have to laugh your way through.
I love this dear companion of mine. We've been at it a long time, and to her I give all the credit for the virtues of our family, including our children and our grandchildren and our great-grandchildren. She holds a very bright spot in their hearts, as do I, and my love for her extends over a very long period of time, and I expect it will go on forever.
The quiet conviction shared by President and Sister Hinckley held throughout the church that a loving bond uniting husband, wife, and children is one of the cornerstones of a strong society and a stable world. Yet statistics showing the disintegration of the family are alarmingly common across the globe. Divorce, neglect, abuse, abortion, addiction, sorrow, and despair, it would seem, are running rampant worldwide. But to the ever-optimistic Marjorie Hinckley, these problems presented opportunities to make a difference. Her answers were rooted in love, compassion, and a desire to uplift others.
It is no wonder that Sister Hinckley was described as charity personified, and we're honored to help perpetuate her legacy of love and concern for others by hosting this lecture this evening. Craig Hart, the director of the BYU Faculty Center and a professor of human development in the School of Family Life, will now provide a formal introduction to Dr. Kenneth Dodge, who will deliver tonight's Marjorie Hinckley lecture.
It's a privilege for me to be able to introduce Dr. Kenneth Dodge to you tonight. He is a Pritzker Professor of Public Policy and Professor of Psychology and Neuroscience at Duke University. He is also the founding and past director of the Center for Child and Family Policy at Duke University. Dr. Dodge is a leading scholar in the development and prevention of aggressive and violent behaviors. His work provides a model for understanding how some young children grow up to engage in aggression and violence. And his work provides a framework for intervening early on to prevent the costly consequences of violence for children and their communities. His current research and family policy interests focus on connecting families to community resources in an effort to improve children's developmental outcomes. We will hear more about that tonight. Dr. Dodge joined the faculty at Stanford University of Public Policy at Duke University in September 1998. He is a trained clinical and developmental psychologist, having earned his bachelor's degree in psychology at Northwestern University in 1975 and his PhD in psychology at Duke University in 1978. Prior to joining the Duke University faculty, Dr. Dodge served on the faculty at Indiana University, the University of Colorado, and Vanderbilt University. Dr. Dodge is currently the president of the Society for Research in Child Development, with a membership of approximately 6,000 researchers, practitioners, and human development professionals from over 50 countries. Honors include the Distinguished Scientist Award from the Child Mind Institute, Research Scientist Award from the National Institutes of Mental Health, Distinguished Scientific Award for Early Career Contribution from the American Psychological Association, and the J.P. Scott Award for Lifetime Contributions to Aggression Research from the International Society for Research on Aggression. Dr. Dodge has published more than 500 scientific articles and was elected into the National Academy of Medicine in 2015. As of today, I just checked, his publications have been cited 118,147 times by multidisciplinary scholars. The positive impact of his scientific contributions has been felt far and wide across many disciplinary boundaries. On a personal note, early in his career, while he was at Indiana University, Dr. Dodge visited Purdue University. This was in the early 1980s. He visited on at least one occasion, and we were trying to remember if it was more than that last night. And that was while I was working on my doctoral degree. I remember well a presentation that he gave and our subsequent discussion on social cognition and aggressive behavior, which was really transformational for me. This and his published work in this area provided the inspiration for my dissertation and for a good part of my research trajectory. I will be forever grateful for his positive influence. I've also seen the immense impact that he has had on multiple generations of students who are professional colleagues in the field today. Over the years, I have observed Dr. Dodge interact with students and colleagues at professional meetings. His charitable, kind, warm, and inclusive manner, his listening ear, and ability to adeptly synthesize complex pieces of information has helped him guide consequential discussions and to generate creative ideas. He is a genuinely wonderful human being who we are privileged to have with us tonight. Let us give a warm welcome to Dr. Kenneth Dodge.
Wow. Thank you, Craig. That's very overly generous. Gosh, I am thrilled, excited to be here. Thank you all for coming. You must be here because you're interested in children and their welfare, and thank you for that interest. I want to thank Brigham Young University and the Hinckley family and all the donors for making it possible for me to be here. I've had a wonderful time so far. I'm really enjoying myself, and I'm really honored and grateful to be here. I want to thank my host, Dave Nelson. You've been terrific, and Laura Ricks, Dean Ogles, everybody I've met today. It's been a great day. I really am very grateful to you. I'm sure I've missed some, but I'll do it tomorrow morning. I want to get on because I'm very excited to talk with you about this topic. Let's see. I want to start by thanking the people who have helped me in this line of work for many years. Funders, many foundations, colleagues, collaborators, students, mentors, faculty, friends, colleagues like Craig and Dave, others in the field. If there's one thing I've learned, it's how to ask for help from my funders and colleagues. And that is the message that I want to give to you tonight. Ask for help. The way to be competent is to ask for help, to learn how to ask for help from the right people. That's a paradox, right? Because you're supposed to do it alone to be competent. But the way to be competent is to ask for help. That's also the message that we have learned to give to mothers and fathers who give birth to a baby. What a task. The way to solve that is to ask for help. I don't know how many of you are parents. I remember when I became a parent, it was the most exciting day of my life. It was also the most frightening day of my life. I felt very ill-equipped. I'm educated. My wife is more educated than I am. And we were frightened as can be. Right? I don't know if you remember it. Right? So that's the message is we're going to learn how to help families get help. All right. Now, I want to talk with you about a problem and a solution. The problem is that the youngest children in our society are not faring well. That's the sad truth and fact. We might talk about how they're not ready for kindergarten. We do know the data and facts about high rates of child abuse and neglect in our country. The fact is that the United States, the wealthiest nation in the world, ranks fourth from the worst, fourth from the bottom in young child mortality, in just getting them to live to kindergarten age. We are fourth from the bottom among all developed nations, all 39 developed nations in the OECD. We are right there at the bottom, along with Turkey, Chile, and Mexico. And yet we spend so much more. Something's wrong. All right, so that's the problem, and I want to talk with you about a solution. Right? Craig nicely pointed out all these academics who are citing my work, but the influence that I want to have and the impact I want to have is on families and children and society. So that's what I'm trying to do, and I want your help in figuring out solutions for it. So I hope we can have a conversation a little bit. All right? I want to start by telling you two true case stories in the research I've done. I've gotten to know different families along the way. And so I want to tell you about two cases, two very sad stories. The first one is about Marisol. She lived in Durham, North Carolina. She had low income. She was single. She had two babies. One was 2.5. One was just under 1. She was trying her best. She was estranged from her family of origin, perhaps because she had these two babies, but there she was trying her best. She had a job as a maintenance worker, an office building, overnight shift. She had a plan. At 10:30, a babysitter would come. She would leave the babysitter with the two babies, and she'd go off and work, come back in the morning. One night, the babysitter didn't show up. She didn't have a backup plan. She panicked. The babies were asleep. She locked the apartment door from the outside and went off to work. 2 o'clock in the morning, one baby woke up, started crying, woke the other baby up, started crying. A neighbor heard, knocked on the door, nobody answered, called the police. They came, they knocked the door down. There were two babies, there's no adult. They arrested her for child neglect. It was 9 months before she saw those babies again, working her way through the system. There's something wrong with this story. She wasn't a bad woman. She was trying to do it. She was trying to do it alone. She didn't ask for help. She had a plan, but she didn't have a backup plan. What could we do to help her as a society? Think about that. Here's the second case. Different. Middle class, upper middle class mother, married, her educated, well-educated, college degree and beyond. Her husband was a business executive. They had their first baby, and she just didn't connect with her infant. She got depressed. And it got worse because she thought she should be a good mother. And she tried, but she just didn't feel it, and she was sleepless, and the baby was crying all night, and she was having trouble breastfeeding, and she thought that she should solve that on her own because, good golly, she's educated and she should know how to do that. And she couldn't tell her husband, and she couldn't tell anybody else, and she was trying her best, she thought. One night, the baby was crying. Her husband was away on a trip out of town. There she was alone with the baby. He was crying, and she was a little slow to get to him. She got to him, knew that he needed changing of his diaper, brought him to the changing table, pulled off his diaper, and he urinated all over her face. She, in a moment, thought that this baby was being mean to her and doing this to her in retaliation for neglecting him. That was what she told me went through her mind at that moment. Now, how can a 6-week-old baby have the intention to urinate all over his mother? But that's what she thought in her mind, and she slapped him across the face, so hard that there were bruises. The next morning, she felt totally remorseful, knew she needed to bring her baby to the pediatrician, did. Pediatrician says this looked like abuse. The whole case unraveled and revealed, and there she was charged with physical abuse of her child. All right, these are two cases. Both of them are sad and tragic, and I don't think they're horrible people. Right? They didn't ask for help. They tried to do it on their own. They did the best they could. They did bad. Right? All right, that's the context. That's the selling. What do we do about it? So in this United States, we try to spend money, and we have spent money on children. This is a graph. You can follow it. On the left is the year, and these are across years, since 1962, how much money we're spending on children as a U.S. government. And the yellow line is the total amount of spending, in billions of dollars. It's just going up. And we're not only spending on all of our children, we are particularly spending on children living in poverty, and that's the red line. That's also going up, right? So we're spending a lot of money. But we've not yet observed population impact. Yeah, we've got programs that work for some families. We've got some solutions. We've got some communities that are doing well, some that are not. But overall, we've just not observed the population impact. Facts are facts, let's be clear. So let's look for a solution. All right, so the goals that I have for you today, and I'm going to race through, is I want to tell you a little bit, just to summarize some of the research I've done on how families come to maltreat or neglect their young child. Just how does this happen? What are the processes and what's going on, like the 2 case stories I described to you. And then I want to respond to a challenge to find a solution, all right? And the challenge was presented to me by the Duke Endowment back in 2001 when they came to me at Duke University and said, you've got a problem. Durham, North Carolina has a high child abuse rate, too high, higher than the state of North Carolina, which was higher than the national average. Will you find a solution? Not for 50 children, but for all children. Let's lower the population rate and do it in a way that you can replicate for other communities so that we have a replicable model, a manual, so to speak, right, for the whole population, and evaluate it as rigorously as science allows, randomized trials, whatever. I said, thank you, no, I don't think we could do that. And they said, what will it take? And I said, well, if I do it, here's the problem. I'm going to want to make you happy, and I'm going to pretend that I have a solution right away. And I won't. And they said, okay, we get it. What if we give you 10 years worth of funding? I said, okay. And we made mistakes. We tried. We did research, some of which I'll talk to you about. We tried. I can tell you about the things that didn't work. But I really want to talk with you about what I'm excited about now that I really do feel has promise. That's Family Connects. That's what it's called. It's called a Family Connects program, and I want to talk with you about it. Then I want to tell you some of the evaluation studies we've done about the evidence about Family Connects. And then I want to end with the current mission of the work that I'm doing with my group at Duke, all right? And then I want to open it up and hear your ideas, your candid ideas. What's good, what's not good? Let's be honest and try to improve a lot of children. All right, Family Connects, as I said, back in 2001, officially the funding started 2002, the Duke Endowment made a 10-year commitment to discover how to reduce community levels of child maltreatment in Durham County, North Carolina. That's where we started. All right, and as I said, the challenge of the community impact was requirements. First, we had to have a replicable model based in developmental science. Second, rigorous evaluation of that impact. And third, the community rate of maltreatment as the primary outcome, not just those 20 or 50 kids families that we might do in some pristine university laboratory study. I don't mean to criticize them, I do them. But really on rates in the real world that we might evaluate by hospital records about children coming in for illnesses and injuries, and Child Protective Services rates for abuse in our communities. Those are the measures that we want to hold ourselves to. So our plan was to study how child maltreatment occurs and how it can be prevented, to pilot some solutions, to evaluate rigorously, and then what we're doing now is disseminating across the country and continuing to learn. In our research, we searched for the silver bullet, the one solution, right? What was going to be the one way to prevent maltreatment, promote infant healthy development, promote kindergarten readiness, do it all, right? We learned, I'm summarizing, 50 journal articles now and all of the years of work. We learned 2 things, all right? First thing is, there's not one reason that families come to neglect or maltreat or fail their children. Instead, families come to that through diverse pathways. I described to you just two, right? The mother who was at low income and couldn't get a babysitter there, and second, the mother, upper middle class mother who was depressed. There are many different stories, right? In our research, we followed 500 pregnant women, randomly selected from prenatal care. We followed them over time through the beginning of kindergarten, found out which ones had indeed maltreated their children or not, which ones had children who were kindergarten successful, et cetera. And we learned, certainly where demographic factors can predict poverty, low income, disenfranchised families, low educated families. But that's a very little part of the story. It's actually a minuscule part of the story. The story is individual clinical factors in families at birth improve this prediction, right? And somehow we have to figure out what each family needs and then provide resources to address those needs. That's not easy. That's not a single silver bullet, but that's what we ought to do. All right, easy enough. What are the needs? In our work, we identified 12 different kinds of pathways, kinds of needs in several different areas. First, parent health care. Parents who are not taking care of their own health care, they're at risk. They're not taking care of themselves. They're not ready to be a parent, right? Infant health care. We have well baby visits, families that are not getting their babies to well baby visits, not taking care of the health care of their baby, beginning prenatally, right? But through birth and then after, they're at risk. Families that don't have health insurance, they're at risk. Families that don't have child care plans, whatever that is, within the family, mom needs a break. She needs respite, right? She needs grandma to come over. She needs some kind of break. Or if mom's working, out of family childcare. Good plans. That first mother had a plan. Babysitter coming at night sounded pretty good. She didn't have a backup plan, right? What happens if the babysitter didn't come? So that's another route. Parent-child relationship. That second mother wasn't connecting with her infant. Management of infant crying. I remember my son crying, Graham, we just couldn't stop him from crying. I remember it. I can tear up just remembering it. But it was wonderful because my solution was, not solution, but what I did was I remember night after night, I would watch videotapes of the Duke National Championship basketball game, right? What a joy. So that's how I made it through. This was back in, 1992. All right, family financial stability, family violence, domestic violence, family violence in the home, history of parenting difficulties, parent mental health, depression, anxiety, substance abuse, and social isolation, lack of emotional support. These are all the different kinds of factors. Not one family has all of these. Different families have different needs, okay? That's the first point. The second thing I learned is that we have no way of delivering those resources to families in our society today. There is no system of care for young children. What do I mean by that? Let me contrast that with what happens K-12 public school system. If you have an 8-year-old child who can't read, the teacher will address it in classroom. If that doesn't work, there's a special education system. If your 8-year-old child has head lice, or a healthcare problem, the school nurse is the one who's going to identify it. Right? That's pretty universal. If your 8-year-old child is hungry and malnourished, we have a school breakfast and lunch program. Right? It's pretty comprehensive, pretty broad. It's not perfect, but it's a pretty universal system of care. Right? We also have that in primary health care. Right? I've got a primary health care. Good golly, I need my internist, right? And it's pretty universal for all of us who can afford it or can get it. But it's pretty comprehensive, right? My primary care physician, I don't have to be sick to go see him. I see him every year. He helps me with different problems. When I do have a problem, I go to him. He might help me with the problem, or he might refer me to somebody else who can help me with the problem. I got a lower back pain. It's bad. That's why I asked for help and asked for this chair tonight. It's a little embarrassing for me to sit in front of you rather than stand in front of you, but I've got to recognize that I've got to ask for help. I just couldn't do it tonight. Bad lower back problem. So thank you for indulging me and allowing that. But my primary care physician will get me to a radiologist and a physical therapist and a neurologist, and I'll get the help I need. That's a pretty universal system of care. Now imagine for families of a newborn, families of young children, we assume parents can succeed alone. In my community, we don't even measure how many 3-year-olds live in our community, let alone how we're helping them, and that's a fact. We know how many babies are born in Durham, North Carolina. We know how many children enter kindergarten, public schools. We don't even know how many 3-year-olds live in the community, let alone whether we're taking care of them as a population. But we assume that families can do it. Families can do it on their own. Historically, families have always done it. Mothers have always done it on their own. Fathers helping a bit too, right? That's what we have assumed, right? But the spending patterns actually show a lack of commitment. So I showed you earlier how we spend a lot on children. This graph here at the bottom actually breaks it down. The yellow bar is how many government dollars are spent per child for children 0 to 5. And the red line is how much we spend per child, children aged 6 to 18. That's where we're spending our money, on children 6 to 18, and even more on the 18-year-olds than the 6-year-olds, and very little on children 0 to 5. Now, if you've been a parent and have watched your children grow across the lifespan and reflect back on it, when did you need money the most? When did you need help the most? Was it when your child was 15? No, it was probably when your child was 1. At least you were younger, you had less income, you had more need, you had more panic, and that's when you needed emotional resources as well as financial resources. So I think we've got it flipped. All right, and as I say, the proof is to ask any mother or father when they need the resources. All right, part of this spending reflects outdated developmental science. So my colleagues in developmental science are partly to blame for this. We used to think that what you did with young babies didn't matter. You know the concept of age of reason? The age of reason is age 7. That's when we thought children could begin to reason. And before that, you didn't have to cognitively enrich them because they couldn't learn anyway. How wrong we were. Right now we know children are learning from the day they're born, if not before. All right, so I want to talk with you about a solution to this problem. Family Connects. It's a system of care to improve population outcomes for infants and families by reaching every birth in a community. Yeah, this is a little big brother. This is a little community imposing, but it's all voluntary. But I think families need the support. So it's a system of reaching out to every birth in a community and connecting with them and assessing and what they need. And then providing help for them, either solving their problems right away or matching them with community resources to meet those needs. Now to do this, universal primary psychosocial educational system of care is what I'm calling it, comparable to what we have in healthcare, right, which is a massive system, right? Comparable to that, we want to build for families birth to 5. That's my vision. That's what we were trying to create. In order to do that, we need an umbrella of community resources, right? That's going to be one part of what I want to talk about. Second, we've got to reach every family. Not just the families who come forward. In fact, the ones who don't come forward probably need us the most, right? And we want to keep it cheap because I don't want to just demonstrate that we can do it at any cost. I want a system that we can bring to every community in the country. So the Family Connect costs about $600 per family, all right? I think that's dirt cheap, right? Think about what we're spending otherwise. All right. This is a paradigmatic shift. Universal home visiting to go out and reach every family in their home because every family is vulnerable at the birth of a child, right? It's a cross-demographic risk. This is not a problem for the poor only. When we've reached every family in a Durham community, and assessed their needs, 94% of all families reported to us that they had a need at birth. We're now reaching into the families' homes when they're 3 weeks old, babies, right? At that, 94% of us told us they had a need. Some of the needs were modest, need help with lactation support, need help with infant crying, right? Some of the needs were massive, domestic violence, substance abuse, maternal depression, all right? But 94% report some kind of need. In this model of system care, all families are eligible. This is voluntary. It turns out, I'll tell you later, 80% of all families and communities accept the offer to welcome us into their home, right? So it's a pretty high take-up rate. As I said, it's similar to pediatric care as a universal primary system of care. I want to be clear, these universal efforts don't replace more intensive, targeted programs. You may have heard of Nurse-Family Partnership, Healthy Families America, Parents as Teachers, other intensive home visiting intervention programs. Those are fabulous. This doesn't replace them. In fact, the opposite. What we want to do is facilitate getting families into those programs that might help them. All right? That's what we want to do. And so we've got some mottos. You know, when families get what they need, no more and no less, the community avoids additional costs. Another mantra is, I want to spend absolutely every penny on a family that family needs and not a penny more. I want to be as efficient as I can, right? All right, so that's what we're going to try to do. There are 3 steps to this Family Connects program that we've created. The first is to connect with every family. We do it by going to the birthing hospital, right? In fact, in Durham, the delivering OBGYN doc and the pediatrician prescribe it, right? They prescribe the Family Connects program. So they're our nurse, and these are nurses. They come in and see the mother and father about an hour or 2 or 3 after the baby's born. Catch them before they leave the hospital. We begin the intervention at that point. We tell them, you can be successful as a parent. You're lucky you live in Durham because we're going to support you, and you can be successful. And there's one thing we've learned. No parent has ever been successful alone. Every parent who's been successful has been successful because they have gotten help. Might be from the grandma, it might be from a sister, spouses, community, but that's how you make it successful. All right, that's what we've come to learn. So then we schedule a home visit by this nurse. We assess those 12 different areas of risk factors. We score them. We do it in a manualized way. So we're connecting with every family. Short term, 3 to 7 times. Keep it short, keep it time limited, because if we're going to give it to everybody, we can't make it too expensive. And then the second step is to connect the family with the community as needed. And those are professional resources, mental health services. They are paraprofessional parent support groups, church groups, neighborhood groups, all kinds of resources, right? In Durham, North Carolina, we've created an electronic directory of 425 agencies that serve families at birth. Churches, temples, neighborhood organizations, mental health providers, child care agencies, the food bank, the food stamp program, clothing banks, housing loans, housing shelters, all of that, right? Just broad kinds. That's what our nurses have available to them to connect families to. All right, so that the parents can connect with the infant. And that last one line is really important. That's the goal, is to help parents connect with their infant. It's all about connection, right? All right. This is a top-down, bottom-up system of care. Top-down is we need to have a policy for generating 425 community agencies, right, and developing a preventive system of care and aligning all of those community resources. And we need to figure out a way to reach and screen 100% of the families, right? We're doing 80% now. I want to get that other 20%. It's also a bottom-up practice, so each family one at a time, right, to identify those risks, develop brief interventions, and communicate and improve their connectedness. So again, the Family Connects model, simple, boil it down, 3 steps. First, nurse connects with the family and identifies the needs. Second, we want the nurse to connect the family to community resources. We want to help the mother and father learn how to ask for help and go to help from community resources. Third, so that the families, the parents can connect with their infant, and that's what it's really all about. All right, 3 different core components here. I've told you a little bit about the nurse home visiting, right, that she does in this short-term way. Second is the community alignment of all these resources. And then the third, I'll talk a little bit about data and monitoring. So let's start with the community alignment. This is a community organization. This is grassroots. This is a lot of policy. This is a lot of government, but it's public, private, nonprofit, for-profit, all kinds of agencies and groups have to get together. In Durham, they've gotten together. We've spent time on it, right? We've gotten every leader we could collaborating involved. So we've got community advisory boards. We've got this electronic agency finder. We've got all of these different steps that are involved. And kind of the way it works is at a clinical case level and then the policy level. The clinical case level is the nurses get together every week and talk about their families, right? And discover problems about community alignment. So one problem in Durham that they said is mothers, especially low-income mothers, weren't going to well baby visits. They weren't showing up for well baby visits at the Lincoln Community Health Center, right? Just weren't doing it. But our nurses discovered why. Here's why. Well, in the housing project, the public bus won't come. They have to walk over a mile to get to the bus stop. They get on the bus, it's very expensive. They're carrying their baby. They're walking a mile. They get off the bus and they've got to walk some more to the clinic. The clinic doesn't take appointments. For well baby visits, they have to sit there, wait, first come, first serve. They're waiting 2 or 3 hours for a well baby visit. And then they have to turn around and go home and do it again. And they said, my baby's fine. I just won't go. So what do we do at the community alignment? Here's what we did in Durham. We went to the city council, passed the law. In Durham, North Carolina today, if you're carrying a baby, you get on a bus for free. Change the bus routes. It now goes through the housing project and everywhere else. Talk to the Lincoln Community Clinic director. I said, why don't you have appointments? She says, we don't have appointments because people don't show up and then we lose out financially. We said, we'll make them show up if you give them an appointment. I said, okay. So our nurses made them show up, right? Sometimes they'd accompany them, right? So they'd tell the mothers, right? So we're just kind of grassroots solving the problem with these community agencies, right? That's at the one level. At a higher level, what the community agencies did is we collected a lot of data on 80% of all the births in several years in Durham, and we learned 11% of mothers giving birth in Durham, North Carolina reported to us that there was a substance abuse problem in the family for which they were ready to have intervention. 11%. Opioids, alcohol, marijuana, cocaine, other drugs. When we had all the community agencies aligned, we could measure the capacity of the community to serve 11% of mothers, and it was nowhere near that, right? Every slot taken up would only be able to serve 2 or 3%. There was a mismatch. We brought that to the city council. With those data, they had to allocate more money for substance abuse interventions for mothers who wanted to stay at home rather than go inpatient to be with their baby. They didn't make 11%, but they made more. So it's at a policy level how we could use this community alignment to change policies and community resources. Second part is that home visit. I've described it to you a little bit. I'll be brief with it. Scheduling a visit, ideally face-to-face by the nurse in the hospital. We spend a couple hours in the home. It's a long visit. We get to know them. We get to connect, right? We sit there and be with the mother and the father. Fathers, as much as possible, we urge them. About 2/3 of all the families, the father participates. We talk about the other third and why and all, but those are the realities for us. It's about 3 weeks after giving birth, and we got flexibility about that. Then we do follow-ups, and then a month after, then we close the case. And then a month later, we call them back and say, okay, we connected you with that substance abuse counselor. How's it going? Oh, you're not going anymore. Why not? And we start over again with them if needed, right? So we're serious about the referrals and community connections. It's not just a phone number. It's really getting them. All right. And then the third part is this data and monitoring. We're creating a child-specific integrated data system. It's an electronic record. It's like my electronic health record. I don't know if you've got an electronic health record. It's saving my life because my lower back pain gets in that record. And when I go to the radiologist, I don't have to tell her what's going on. She's got my history. When I go to the neurologist, they've got the history. That, oh, you've already had an injection 2 years ago and you had surgery before. Oh, let's not try that physical therapy. We've done that before. That's an integrated record. We don't have that for families, right? So we don't know a child coming into kindergarten. The kindergarten teacher doesn't know if the child was an early Head Start or had intervention early. Right? Or the mental health provider at age 3 doesn't know that prenatally the mother was in some kind of counseling program. We don't have that. So we're trying to create this child-specific, it's kind of a family electronic record. We are very lucky. We are getting consultation from the guy, Steve Ballmer, former CEO of Microsoft, current owner of the LA Clippers basketball team. We're lucky that he's our consultant on how to create an electronic record. So we're using Salesforce, it's a private big company. We're investing a whole lot in it. I'd be glad to talk with you more about it. Let me get to evaluation. So we randomly assign every baby born in Durham, whether they wanted to be in a study or not, every baby born in Durham over 18 months, that was 4,777 babies, to intervention or control group by the date they were born. If you were born on an even-numbered birth date, you were assigned to receive the Family Connects intervention. If you're born on an odd-numbered birth date, you're in the control group. The nice thing about that is, and this past ethics boards, IRB, the nice thing about that is we could use administrative records. So we could go to the Child Protective Services records and examine, are there more child abuse cases for even birth dates or odd birth dates? Right? To see. We don't have to bother you with the evaluation. We don't have to restrict it to volunteers. It's the whole population. All right, so that's how we're evaluating. We implemented the intervention. We did interviews. We had a different research team who knew nothing about us, contracted to come in and interview families when the baby was 6 months of age. So this is a follow-up. So we've got some interview data, and then we've got these administrative records. We've replicated it in a second randomized trial because replication's the name of the game in the world I live in, and then a third field quasi-experiment. All right, implementation results. We can do this. As I said, 80% of all families scheduled a home visit and started the intervention. Of those, 86% completed the program. Mothers and fathers want this. This is not a hard sell. Remember when you became a parent, right? You were frightened, and I think you'd welcome a nurse coming into your home and just telling you your baby's alive, right? And healthy, right? Or what you need, right? I remember becoming a parent, and actually I was home visited back in 1991 several times. We adopted my first son, and the laws in Tennessee were that you had to be home visited by social workers, right, just to see if you were up to snuff and safe and all. That was wonderful. I mean, I just like, wow, thank you for coming. I know you're here to inspect me, but let's give me some help too, right? All right, so families want this. We could also do this reliably. There was a fidelity to our home visit protocol. We had independent inspectors, 86% reliability and scoring. Those are the details. But we also were successful in making community connections. As I said, 94% of all families identified a need for us. Now, of that group, 49% of all families, the nurse could resolve the need. Lactation consultation, our nurses are certified and expert in that. They could help work that out, right? Or if there's an infant sleep problem, they could give them some strategy. Or if they simply want to know where's the best child care, we go to our electronic data system and we could say, all right, you're going to go take a job over here. There are 3, you want a high quality child care. You want in North Carolina 4 or 5 star child care system because you don't want a poor quality. We want the best for you, right? And by the way, you qualify for a subsidy, so let's fill out the form. And by the way, my computer says there are 3 5-star child care facilities between your home and work. Let's go here. Let's try that one out. I've got an appointment for next Tuesday at 2 o'clock in the afternoon. I'll bring you there. Let's go see if this is where you trust people to take care of your baby. Oh, you don't want that? You want a babysitter instead? Or maybe you want to stay at home and figure it out? Okay, let's work it out. That's the sort of way we do that. For 45% of all families, we did refer to community resources, right? Mental health providers, all of those other programs that I've described to you, and 79% of those families were successfully connected. So these data aren't perfect, but they're pretty good. We can keep making them better and better, right? But we're very data-driven in this. All right, randomized trial. We've got families assigned to intervention, families assigned to control. Compared to control families, those assigned to Family Connects, whether they actually got Family Connects or not, but those assigned to Family Connects, indeed at age 6 months had more connections to community services. Great, that's approximately what we tried to do. What impact does that have? That brought down maternal anxiety and depression, right? Mothers were feeling less anxious, less depression scores on the Edinburgh Depression Scale, more self-confidence in parenting, right? More comfort. Whew, things are a little better off. That then also related to more mother-reported positive parenting behaviors, higher quality parenting as rated by observers who didn't know whether they got the intervention or not, higher quality and safer home environments, and higher quality childcare, more 5-star childcare facilities when choosing out-of-home childcare. There was no impact on whether they chose out-of-home childcare or not. We didn't take a stance on that. We wanted to listen to mothers and fathers' preferences about that. If they did choose out-of-home childcare, it was better quality. All right, all those are good things, but here's the big one. This is the one you got to watch. We went to the hospital, the 2 hospitals in Durham. Duke Hospital and Durham Regional Hospital serve all the families, right? We went to the records of those hospitals when the children were 5 years age, 60 months of age. What I've got graphed here for you are the cumulative emergency medical care, injuries, illnesses, coming to the emergency room, overnights in the hospital, all right? Over 5 years. The red line is the control group. That's kind of the natural life course. There's a lot early on, and then it kind of smooths off, all right? The blue line are the families randomly assigned to the Family Connects. Less at every age, and it lasts. It's about a third less, all right? Injuries, illnesses, emergency child care. Whew. This one, we went to the State Child Protective Services Administrative Records. Who's reported for child abuse? Same thing across the first 5 years of life. The red line is the control group. It's not one of those tailing off curves. It's not as pretty, but it's going up. The blue line are those families assigned to Family Connects. It's less, and it lasts, and it's about a third less. All right? Whew. Now, that worked in the first trial. These are detailed data that we had to do it again, right? In a second, we had to replicate it. So let me just briefly walk you through it. RCT1, the first column, is the first trial. We were able to implement, I said, the study at 4,777 families. Of those, 2,327 were assigned to the intervention, right? Just descriptively, about 61% were Medicaid recipient families, an indicator of low income. All right, what effects do we have? FC is Family Connects, C is control. In terms of the number of community connections, Family Connects is higher than control. Maternal anxiety, depression, good. Family Connects is less than the control. Positive parenting, Family Connects is better than the control. Emergency care episodes, Family Connects is lower, which is better. Child Protective Services, Family Connects is lower, that's better. That's what I said. All right, now we go to the replication trial. Not as big, but we tried to replicate it again a couple years later. By this point, 68% of the families were Medicaid families. First one, number of community connections. Yes, we replicated it again. Family Connects family had more family connections. Second, maternal anxiety, Family Connects families were lower. Great. Positive parenting, no difference. We didn't replicate it. No effect on parenting behaviors at 6 months of age. We're worried. We take it seriously there, all right? Emergency care episodes, we replicated it, but only among the high-risk families. We didn't replicate it among low-risk families, so I'm a little worried, all right? But we replicated the effect with Child Protective Services. All right, so I got to do it again. So we did it again in a field trial in rural eastern North Carolina, a different community, 4 counties, not implemented by us, but implemented by different people. 994 of them, 69% Medicaid. We again replicated the Family Connects Community Connections finding being better, maternal anxiety going down, being better, but again, no difference in positive parenting. I now conclude that this program is not going to improve parenting across the life course. We're going to need a booster shot. We're going to need some other intervention, right? And I'm working on that, and I'll tell that to you in a minute. We did replicate the emergency care episode, so I feel more confident that we reduce emergency care use. $600 a family is going to reduce emergency care utilization for injuries and illnesses. I'm confident about it. Child abuse, the last one, well, that's still in progress. We don't have the data yet. We did a benefit cost analysis. I'll just be very quick about it, right? All these formulas about how to do it, but it's simple, right? The average cost of emergency medical care billing for our control group was $3,500 a family. The average medical care cost for the Family Connects group was $1,200 a family. The cost of the intervention was nothing for the control group. Obviously, they didn't get any intervention, and $700 for the intervention group. All right. Benefit cost ratio, we saved $3.17 for every dollar we spent. Private health care insurance providers ought to like this. All right. So we're disseminating the program now, and we're continuing to study it. I'm not yet perfectly confident that it's going to work everywhere all the time, and so I want to evaluate it virtually everywhere we go. I'm a nerdy academic trying to have an impact in communities, so we're disseminating. We're in 43 communities. We haven't marketed, we haven't gone out to anything. All of these communities have come to us. And so we're responding to them, right? We're disseminating Family Connects program in all of these different states. Some are small, some are big. Small, Peoria, Illinois, Colquitt County, Georgia, right? Big, the entire state of Oregon is adopting Family Connects. How proud could I be? Legislation was passed last year heralded by State Senator Elizabeth Steiner Hayward, a pediatrician. The state of Oregon will deliver Family Connects to every baby born. There's about 45,000 babies born in Oregon a year. How are they going to finance it? Well, we've got a creative way. 1/3 of the cost will be borne by the federal Medicaid program. 1/3 of the cost will be borne by the taxpayers of Oregon. And 1/3 of the cost will be paid by private health care insurance providers, mandated to do so, Blue Cross, Kaiser, you name it. Not one of them has objected. They realize that if they pay for it, they're actually going to save money in the long run. All right? So we're out there. We're in Chicago, my hometown. How could I be more proud than that? And so these are the different communities. And so that's what I'm doing now, is going around to these communities, learning about what they do. Some of them Family Connects is not right for them. I'm more interested in working with them to provide solutions to address early childhood system of care. And if I have a hope and a dream, it's that in 10 years, none of you will remember the word Family Connects, but every community in the country will have Family Connects in some generic form, right? That's my hope. I want to close by telling you about the innovations that we're doing. This is what I'm doing right now. All right, so I've given you one slice in the lifespan at birth. I know families live across the lifespan. We've got to do this prenatally. Go, right? Meet with mothers and fathers prenatally and find out what they need. So we're developing a prenatal version, reaching out to every person, every mother and father prenatally, to do the same kind of thing, to learn what they need. We're also piloting postnatally. We're going to try to do this at every birthday. So 12 months, 24 months, 36 months, we're developing postnatal versions of primary psychosocial care. We're collaborating with pediatric practices to do it in that context. As I said, we're working on this family-based electronic information system. So in Guilford County, North Carolina, one way to do it, I don't know how the public schools work here, but in Guilford County, when you enter kindergarten, you get an ID number, right? And that ID number carries with you across the school. In Guilford County, they assign that ID number at birth at the Family Connects visit, so that we could make sure the records are connected, all right? Any Head Start, early Head Start, substance abuse program, child care program they get in early life is going to be connected to the public school record. Again, voluntary, mothers can opt in or opt out. And it's amazing how much they opt in. but it's a voluntary system. All right, we're also innovating with diverse communities. The state of North Carolina has come to us and said, we have tribal communities in western Appalachian, North Carolina. Will it work with them? Very different culture. So we're innovating, right? We know it can't be the same in every community. And then also, lastly, we're working on a lot of innovation in the financing. How do we pay for this? How do we pay for this as a community, as a society? How much should be government? How much should be private taxpayers? Just how do we do this? That's a political issue. It's also a financial issue. Every community is going to have it different, right? All right. We're putting it all together in Guilford County, North Carolina. We have a $100 million budget. Whew. From Blue Meridian Partners, which is 8 billionaires that have given this funding, to Guilford County. 6,000 babies are born there a year. We're going to find them prenatally. First of all, we've got to get them into prenatal care early. Then we're going to find them, deliver Family Connects at birth, deliver these post-natal interventions, and watch them through at least the beginning of kindergarten, and see if we can have a population impact, right? Whew. Can we do that? That's what excites me. Let me close. Can we accomplish this new system of care for all families of young children, and how can we pay for it? With that, let me close and invite your questions. We have time for questions?
So as we do questions, just you can raise your hand, and then we have some roving mics, and we'll take 2 or 3 questions, 10 to 15 minutes worth, and then we'll end.
Thank you. Yes, sir. There's a roving mic somewhere, or speak. All right, you got a booming voice.
Is Durham, North Carolina.
Yeah.
And why don't you have a Durham accent?
I grew up on the south side of Chicago. I used to have a Chicago accent, but that's where I grew up in the south side of Chicago. I moved to Durham a number of years ago. My wife's from Durham, and so Durham is our home now, and I've lived there for over 20 years. Right? My mother and father are still living in Chicago, and I go back there. That's my hometown. So Durham has about 3,400 births a year. It's a community of about 300,000. It is a county government with a city and a county government system, which makes it nice. Duke has a pretty much monopoly on the healthcare, pediatricians, OBGYN, hospitals and all. That makes it a little bit easier. And that makes it challenging then when we disseminate to other communities. Durham is a fascinating community because it has a lot of poverty. Poverty rate's really high, the violence rate is really high, drug use rate is really high. It's got a lot of problems. It also has a lot of resources. The universities, the research trying, a lot of wealth, a lot of education. All right? We ought to be able to use one to solve the other. Right? Yes. Yes.
I've done a lot of work with the school district in
Yeah.
this town, and I'm wondering how you account for transition rates. We have a high transition rate in our school district.
Yes.
Children coming in and out. How did you account for that kind of thing? And
Yeah, it's true.
bless
Also
your heart,
birth to
you're
5.
doing a wonderful thing, by the way.
Right. So we've connected birth records with school records. And yes, there is some movement. In Durham, about 22% of the births don't show up in public school. Right, so that's about the migration out, and there's also about a similar amount of migration in. In our longitudinal studies, we've got to go out and find them anyway. It is a challenge for communities, and it is a challenge some community leaders tell me. Why should we put all this money in families at birth if they're just going to move out of the county anyway? They're here for school, and then they're going to leave. Others are going to come in. That is a challenge. How do we do that with public schools? The way we do it is you transfer records, and you hope you have some similar kind of education system across counties and states. Gosh, if we made Family Connects universal, you move from Provo to Durham, you could still continue on in the Family Connects program. Wouldn't that be nice? That's dreaming. But yes, that is that's an important problem you've raised about migration. Yes. And then here.
Hi, so I have a loud voice, I'll talk loud. Oh, thank you.
Yeah.
First, I wanted to say thank you. This was really fun to be here and to see what an awesome system is being created, and I hope it continues to spread. I wondered if you have any insights on maybe creating an online presence with it, like instructional videos or something, where it can spread to more people, especially if they're in more rural communities or something?
So by online presence, you mean delivering the program online? Or, so, yeah, great idea. And challenging in a number of ways. So I've got to go out and fundraise, right? Because the community's not going to pay for that. But what a great idea. We've got all these manuals and all these interventions nurses do and all these ideas and all. Yeah, I'd love to do that. So if you know a billionaire, send them my way. In Charleston, South Carolina, they're very into telehealth. And they want to know if, especially with remote rural communities, can we deliver this remotely? We're trying it out. I have some doubts. I guess my doubts are stemming from the belief in the wonderful thing that happens when I can look you in the eye and you can look me in the eye and we can shake hands and we can be together. I believe in that. But I also believe that once we do that, maybe the follow-up visit can be remote, right? Virtual, telehealth. Maybe we can, maintain things. So I do believe that in that possibility. So we're working with folks at the Medical University of South Carolina to try for that. If you have other ideas about other online ways of communicating ideas, I'd love to get together with you because we have a modest website, familyconnects.org, but it could be better. There was one. Yes, sir.
Does father engagement in Family Connects boost impact?
Great question. I don't know the answer to that. I haven't studied it well enough. And we haven't done any randomized trials, so I don't know about the quality of our causal inference. But it's a great question. I can tell you what our nurses say, and what we know is that most of the time, yes. And I've got years of experience on this, and I'm a father and care about this, and I'd love your wisdom. So early on, we didn't include fathers. What a mistake. Then we started, we're going to include fathers, and we're going to tell the mother that we want the father present. The mother participation rate went down. There were some mothers that don't want the father. We're getting into family business here, right? Some don't. So now what we do is we encourage, we say there's a father. We'd like the father to participate. Mom, do you want the father to participate? We, at the moment, are taking the mother's lead. If she says yes, that's great. We do it. In fact, sometimes she'll say, yeah, but he won't listen to me. Could you ask him? And we'll say, great. Sometimes she'll say, no, he's out of my life. That was a mistake. I'm going to do this on my own. And we respect the mother at that point. I don't know that I know the best about that. And I don't know if actually getting the fathers involved improves the outcomes or not. It's a great question to study. Yes. There. Pardon?
Can you return to the slide?
Sure.
With the 12 needs of families? Thank you. That was it. Just stay there.
All right. That was easy. Yes.
You shared how you would connect X percentage of families to community resources.
Yes.
Did you guys financially support community resources, or are these all existing community resources?
That's a great question. So we did not. A lot of communities really do need to increase the infrastructure of community resources. But a lot of communities aren't using community resources efficiently. So I told you the example of how in Durham, there wasn't enough community resource going to substance abuse intervention. There might well be interventions available in community resources that the community doesn't need, right? I want to be fiscally neutral on all that. But we can, with this electronic system, we could try to identify those. You know, the reason that you have empty slots is that the community doesn't need your particular kind of service. And your service, you know, as waiting lists, let's grow it. We don't provide those resources, but we work with communities to try to provide more resources. But another thing we've learned, maybe I'm being a little, I'll go ahead and be grandiose, right? But take me with a grain of salt. Here's another thing we've done. We've helped community agencies become more efficient. Community agencies that provide resources for families do not want to be in the business of finding families. They don't want to be in the business of no-shows. They don't want to be in the business of serving families that are ineligible. They want to deliver a service to families that are going to benefit from their service. So we say, we're going to take all of that away from you. We'll find the families. You tell us what kinds of families you want. You want substance abusing moms, but not so severe that they need inpatient, or not this or not. That's what we're going to get you. And our nurses then find the families, get them, try to, you know, make sure there are no shows. And so that community agency can now serve more families with intervention because they're not wasting resources on no-shows and recruiting and finding families and all of that. So maybe they can do a better job of serving with the same number of dollars. They could serve more families. That's my grandiose hope. I haven't studied it. It's one of the studies I want to do is, are we making community agencies more efficient? Right? If anybody's a business student out there or a finance student wants to figure that out, I'd love it, right? What I'm telling you is there's more research questions and more things to study here than I possibly have time to do. But that's a great one about community agencies. Right? Yes, sir.
Are you using credentialed nurses, or are you creating your own nurse skills?
Great question. We are using bachelor level credentialed nurses, for whom, public health nurses, for whom we provide additional training. Not all nurses are good for this. NICU, neonatal intensive care nurses who like tubes and all of that, aren't comfortable going into people's homes all the time, so it's community nurses. But right now we're using those credentialed nurses. A question is, are there enough to go around? Let's say my hope gets, accomplished and we're universal and the whole, are there, I don't know. We've got to do we're doing a labor market analysis. We're also with urging from the state of North Carolina, where they say, we'll consider going statewide. There's 125,000 babies born in North Carolina a year. But will you have enough nurses? What about using LPNs? Or what about using doulas or community health workers? Could they do it? Social workers. We tried social workers. I love social workers. Social workers, mothers wouldn't let into their home because they think they're taking their baby away for abuse, right? So social workers are part of the team. Mothers love nurses. But, we're exploring alternative, credentials. And we're collaborating with Hofstra University, I hope, we're trying to collaborate with them because they've expressed an interest, School of Nursing, in developing nursing training programs. Right? I think it's a whole field, not only our program, there's a whole lot of nurse home visiting programs out there. So that's another part of all of this, that we got to think about. Yes?
A quick question of mine is, I think a lot of maybe these problems that happen with young, especially I think maybe young family, low-income families, I think a lack of education often leads to panic and these sorts of things. Is there any maybe education, or before you become a parent type education regarding, involved in the program? Because, for example, something I love that I think the state of Utah has done is that they'll give young couples like a discount for a marriage license if they get marital education classes or something before getting married. So something like that could just promote, let's at least teach you something.
I love it. It sounds like we've just identified a career for you. Could you do that?
It's one of the things,
I think it's a great idea, right? I mean, we are so behind in the way that we support family, this families and becoming a family and all of this. What I'm talking about is just one little slice. So absolutely, please do it. Yes?
when my children have all gone through high school, and they've typically done, workshops and medals, and cooking and things.
Yeah.
And how much I wish that they could do premarital.
Wouldn't that be great?
Childcare classes.
Maybe there ought to be a license required. But everybody is, I've never, and maybe there's one here, I've never encountered a mother or father who said, I had it licked, I knew exactly what to do at the birth of my first baby, and I had no panic. Good golly, I've got a lot of education. My wife's got a lot. As I said before, we were panicky. We were so ill prepared. I mean, and we didn't have any education classes, and we thought we knew what we were doing, and we didn't, Gosh, I was really lucky. We adopted my baby, so we were at the hospital when he was born and interacted with the teenage biological mother. And the day he was born, she invited us to come and be there for childbirth. So we were there, and we brought our baby home. This is a true story. 1991, February 27th, my wife and I are driving home with our baby in the back seat with the car seat that the hospital gave to us because we didn't have one. And on the way home, we looked at each other and said, you know what? We better stop at Walmart and buy some diapers. I mean, that's how ill-prepared I was, All right? Oh, yes.
Hi. Hi, I'm from a really small town on the reservation, just like right in the Four Corners area. And we have like so many different, abuse is like one of the number one factors that happens on there. But you just mentioned a lot of doubts within rural communities, and I just wanted to know what they were.
I presented a lot of, sorry, I didn't hear the last part.
You just said that you had a lot of doubts about moving this program into a rural community.
I don't have doubts. I have a lot of hopes, but I have a lot of recognition that we're going to have to adapt the program for different communities. We have implemented the program and evaluated in 4 counties in rural eastern North Carolina. I don't know if you know much about that area, but if it were a country, it'd be one of the poorest countries in the world. And we thought we would have trouble. Our participation rates were actually higher. Our travel costs are a lot higher because our nurses have to drive a long distance. Pediatricians love us because we were doing some things that pediatricians would otherwise try to do but couldn't do. Weight checks, health checks, that sort of thing. There aren't as many organized community resources in that rural area, right? So, instead of the professional mental health service provider, there's grandma a mile down the road, or there's the church providing support, or there's the Rotary Club. We start using them, right? So it's different, and we need to adapt, and we need to make sure we can get into the homes. And that's why I say Western North Carolina, I don't know yet. Can we get into the homes in tribal communities? I don't know. I want to try. I want to evaluate. Let's be serious about this. Let's not assume it works. Let's not assume it doesn't work. We need a whole team of people. So everywhere we go, we try to collaborate with some local evaluators. So in Oregon, we're collaborating with the University of Oregon, Chicago, it's with the University of Illinois, Chicago, and Austin, Texas, it's with the University of Texas. We're trying to collaborate and use the wisdom to adapt. Four Corners region of Utah, I don't know. But you say abuse is a big problem. Let's get there. Let's figure it out, right? I also have to say that I'm amazed at how open communities are right now in this country. They want us. Not that they want us, but they recognize a problem and they want a solution. I just feel a moment in the history of our society where maybe we're ready to prioritize families at birth. I mean, I hope so, but 1 or 2 more? All right. Yeah.
So I had a question on the electronic identification number that you had.
Yeah.
Do moms have to approve everything that goes on the record, or when they opt into the program, do they opt to put everything on the record, and do the kids ever find out that they have this record on them?
So I don't know about the kids yet because it hasn't been around long enough, and we're trying out different ways. I want to make it easy. So the vision I have is that the nurse will have an iPad clone tablet, and we'll give it to the mom, and she can point and click. Yeah, you can communicate everything to my pediatrician. You can communicate everything to the Head Start program. Or no, you can't communicate about my own mental health history, right? Or my marriage. Whatever, right? We're point and click. It's got to be HIPAA approved. It's got to be approved by those other agencies. So it's not so easy to think about, all the signatures and requirements there are. But on the other hand, I bought my home online by point and click with DocuSign, right? So we should be able to do this electronically, right? So that's one of the things we're trying to figure out. And then this record gets created. And the mom's in control, right? She can withdraw consent at any time. Technically, that's true with your electronic health record, although sometimes they don't make that so clear. But, mom has control of the baby's health record, too, in the same way. Are we ready to stop? Yes. All right. Out of your way. Yeah.
So this is his first visit to BYU, and we hope it's not the last visit. We hope he's able to return at some point. But as a reminder of your visit to BYU, we want to present you with a gift. This is a clock that has inscribed on the front, Marjorie Hinckley Lecture, Dr. Kenneth Dodge, Duke University, 2020.
Oh, my goodness. Well, thank you.
Yes.
That is really very thoughtful. Thank you.